So yeah, hi everyone. Welcome to this FCI webinar on artificial intelligence at MCBK. You can see we've got Paul Atkinson, Barry Daniels, Shareth Damdata, Victoria Faint, quite a few people joining. So yeah, I'll just go through this housekeeping quickly, and then I'll hand over to Jeremy, who's presenting the webinar. So as you can hopefully see, we're gonna, if you could all stay muted during the presentation. You can do that with the mute button in the toolbar there. We will be using the chat function, the show conversation bar there. For 1 second.
Them both. Do you know how her love was found?
You've muted yourself, Joe.
Sorry. I was trying to mute people joining. Thanks for letting me know. So yeah, we're going to be asking questions in the chat. We'll be posting it up on the website afterwards and recording it. So we are recording at the moment, so that you all know. And yeah, I can hand over to you, Jeremy, if you're ready to go. 1 second. I think Jeremy may also be muted. Sorry, Jeremy, could you unmute yourself?
Yeah, I just have.
Brilliant, that's great.
Thanks. I'm just sharing my desktop. I don't know if you can see that.
Yeah, that's coming up. So if you, yeah, there we go. That's presenting now.
Great.
Jeremy,
okay.
we can see your desktop, but I don't have a chat option because I'm not in the tenancy, I don't think.
We did have some issues with this before, with people not being able to access the chat. I think maybe once we get to the Q&A, Paul, if you put your hand up if you have a question, we'll try and get to you, if that's okay.
Okay, so shall I get started? And I'd just like to acknowledge the input of the members of the UK MCBK steering group. And Philip, I see that you're on the call today now, acknowledging your input, and your name comes up at the end as well. So this webinar is about computable knowledge and why I and a few others around the UK believe it matters. So I'd like to just introduce knowledge in medicine, a little bit about what I understand by the term knowledge and some of the challenges around knowledge. And then really as a justification for this focus on computable knowledge, evidence that knowledge-based decision support systems do actually make a difference clinically, first of all to medical decisions, and then secondly to patient outcomes. And then a little bit more detail on computable knowledge and how it differs from human readable knowledge, and an explanation about how this knowledge gets used in a range of software tools around healthcare. Of course, there are challenges around acquiring and using computable knowledge, sharing it, and it's really to address those challenges that this global, going through the agenda, current challenges in acquiring the MCBK vision, and then finally some technical and other barriers that need to be addressed around MCBK. So to start with, we really need to wind right back to what information is before we start thinking carefully about knowledge in medicine. Claude Shannon famously defined information as the commodity that reduces uncertainty, and more recently in the first textbook of the discipline in 1990, Ted Shortlift from Stanford defined information as organized data or knowledge used to inform decisions, and I've certainly found that a very helpful definition in my work. So if you think about the cycles of information in healthcare, starting off with patient care or increasingly self-care, that generates data, individual patient data, which we capture in records, traditionally paper, but increasingly electronic, and of course then use it to inform clinical and self-care decisions. But that data in records can also be analysed to generate insights through a whole range of different analytical techniques, and those can be used for quality improvement purposes and for a variety of other local purposes. They can also be used through research to generate clinical knowledge, which is transferable information, which is true not just about one individual patient, but about potentially all patients. The problem with clinical knowledge is that it can sit in a textbook or on a website and not actually get used. So one of the big issues is providing access to knowledge or implementing the knowledge, and the whole field of implementation science, which researches how to use clinical knowledge to impact patient care. Quite often that clinical knowledge would be in the form of practice guidelines, for example. So that's the full cycle of information in healthcare. If we compare now patient data with clinical knowledge, as I mentioned earlier, patient data applies only to a single patient, whereas clinical knowledge should apply to every patient if it's being properly developed and validated. Clinical knowledge originates typically in research on many patients. Sometimes it can also originate in research on lab specimens. It can take a whole range of different forms, as can patient data, but they're typically different forms. There aren't really any privacy issues with clinical knowledge, whereas there are significant issues with patient data, even if it's so-called anonymized. But there are some intellectual property issues, which you don't normally get at the individual patient level. What's really fascinating, though, is that while patient data is a massive scale activity in the global market, electronic patient records, etc., there's really quite a small market globally in computable knowledge, really small and quite fragmented. Different organizations using their own representation, very poorly disseminated standards and so on. So there's really quite a big difference between clinical knowledge and patient data. So really just coming down to focus even more on a definition of knowledge. If you look in a dictionary, it's about understanding and information about a subject that you get either by experience or study. But I found that the second definition much more useful. This is a definition that Alan Newell, who was the president of the American Association for AI, and he wrote a nice article in AI magazine 40 years ago now, and he talked about the property of intelligent agents that allows them to reach their goals efficiently. That's what knowledge is in AI terms. It's also a good definition of knowledge in human terms. It's a property of people that allows them to reach their goals efficiently. And in a couple of articles in The Lancet, I talked about the use and sources of clinical knowledge, and I talked about knowledge being information that supports clinical decisions and can be applied across many patients. So we have to accept that there are at least two forms of knowledge. There's explicit knowledge, which I'm largely talking about here today, which is knowledge that can be readily captured, written down and communicated without ambiguity. If you like, it's what we learn by reading. Whereas there's also tacit knowledge, and that's much more about intuition. It can really only be learned by experience and making mistakes and passed on over a period of apprenticeship. And the picture shows a titanium necklace that I made for my wife, which took me quite a long time to acquire the skills and to make the equipment to actually produce something like that. And plenty of mistakes along the way. And I also learned from various other experts in the area. So that's an example of tacit knowledge or skill, what you need to carry out a craft. So I mentioned already that explicit knowledge is really what we're focusing on here. That's not to say that tacit knowledge isn't important, but in healthcare, we are very good at imparting and regulating tacit knowledge. And that's what, for example, a medical training does. The GMC inspects medical courses to make sure that not only is the explicit knowledge content right, but also the tacit knowledge and attitudes that young doctors acquire are the right kind. So who needs clinical knowledge and what do they use it for? Well, there's a whole range of users of clinical knowledge. It's not just doctors or nurses. If you're a member of the public worrying about your health-related risk or what to do about an acute symptom, what the diagnosis might be, that's a case where you might need clinical knowledge. If you're a patient with a diagnosis, someone with a long-term condition. Now, we talked about a range of people who need clinical knowledge. Even public health workers, medical publishers, and software developers all need clinical knowledge for a whole range, including, for example, can you hear me?
Yes, it's cutting out slightly, but I can hear you.
Good. Even for medical devices, chatbots, clinical robots have knowledge embedded in them. So the next slide. However, there are a whole range of challenges posed by clinical knowledge. First of all, there's a great deal of it, and even going back to 1976, there was a study that Anthony Gorry did and published in Annals of Internal Medicine. At least 3 million facts are required for general internal medicine. I looked at the volume of the medical literature and the rate of change and discovered there was a doubling time of 19 years, and that was, again, nearly 40 years ago. 30 years ago. Andrew Ballas discovered that there was a delay of 18 years in getting new knowledge into practice. Again, that's nearly 20 years ago. There are also some technical problems. If you just delve into clinical knowledge, you find all sorts of synonyms, abbreviations, there's ambiguity and ambiguous abbreviations as well. And there's also some real challenges around the quality, ranging from expert opinion to systematic review evidence. And obviously the evidence-based movement has its hierarchy of evidence to try and address some of that. Next slide. If we look at how that knowledge can be used to overcome some of the delays that Andrew Ballas came up with, knowledge-based decision support systems have been around for a very long time now, and they're potentially a very good way of getting knowledge into practice. And essentially, they're quite simple things. They include two major components: the inference engine and the knowledge base itself, which is knowledge represented in computable format. And essentially what they do, you put in data about your patient. This is assuming you're a clinician. Put in data about your patient. Hopefully you don't have to do anything much other than link the decision support system to the EPR. And then out of that comes patient-specific advice to help you manage the patient. Now, of course, you have to ask, where does that knowledge base come from? Well, there are at least two routes to getting the knowledge into the system, to develop the knowledge base. There used to be people called knowledge engineers, and they could, for example, mine a guideline PDF document or talk to a clinical expert to try and build that knowledge base using some special language and knowledge representation methods. An alternative, which is increasingly important now, is machine learning. And for that, you need a large clinical database with validated outcomes or diagnoses, whatever. So there are at least two ways of constructing a knowledge base. And typically for a machine learning project, you'd end up developing an algorithm as a result of that machine learning project, and that would become the knowledge base for the decision support system. So that's knowledge-based systems in one slide. Do they actually help? Well, yes, they do. There's, for example, a really good series of 6 systematic reviews from McMaster a few years ago now, analysing 166 trials of clinical decision support systems for a range of different tasks, showing that they did improve. About half of the trials showed an improvement in clinical decisions or the care process, so for example, prescribing or hospital discharge. Rather fewer of the studies actually looked at patient outcomes, but of those that did, about between 15 and 30% of the trials showed an improvement in patient outcomes. That's from Pavel Roshanov at McMaster. Next slide. There is a more recent systematic review in JAMIA looking at outcome studies specifically, but this only includes about a quarter of the studies they included were trials. This is a wide range of study designs. Nevertheless, it's still quite interesting. The graph shows the results. There was a reduction in events, a reduction in life-threatening, and 7% of the studies showed a reduction in mortality. About a third, 29%, showed no effect, and actually one study showed harm. That was about increased hypoglycemic events, probably due to tighter blood glucose control. They looked at the different care groups or disease areas in which the systems were most likely to be effective and had medium or low risk of bias. And it turned out that managing blood glucose or blood transfusion, or preventing a range of conditions including physiological deterioration of pressure ulcers, acute kidney injury, or venous thromboembolism, that there was reasonably good evidence that the decision support were helpful there. Another interesting finding from that Varghese systematic review is that 3/4 of the algorithms were rule-based, so they were computable knowledge, explicit knowledge, 6% were Bayesian nets, and 22% were not stated. And that probably reflects the fact that this systematic review covered a period of time when machine learning was perhaps less important and popular than nowadays. Next slide. So we need to think about computable knowledge. We've seen from the previous systematic views that it can be highly effective, really quite effective at improving patient outcomes and clinical decisions. But it's not the same as human readable knowledge. Human readable knowledge is the knowledge that's stored in text format, whether it's on paper or online, PDF leaflets or guidelines. That's all human readable knowledge. And although you can carry out optical character recognition by computer, that still doesn't make that knowledge computer understandable. It's got to be represented in a very granular way, and we'll see an example of that in a moment, to what makes it computable. Computable knowledge is computer executable knowledge. We call it computable knowledge for short. And it's held in a format that the computer can actually understand, in inverted commas, and use it to carry out a task. For example, a calculation, or interpreting a lab test, or displaying an alert or reminder, for example, for prescribing, providing advice or decision support, or instructing a syringe pump or a surgical robot to carry out an action. So let's have a look at an example of that. Here's a nice pathway on gestational diabetes. And this is the human readable text in the pink box on the left, or apricot coloured really. So there is text here: at the booking appointment, determine the following risk factors for gestational diabetes, and there's a list of them, a bulleted list. If you wanted to represent that in computer understandable format, it suddenly gets much less understandable. But here's an attempt using a language called CQL. So the first thing to do is you define something called the gestational diabetes risk, and it's there if the common conditions indicating gestational diabetes are present, or common laboratory tests indicate, or common family. You could see the similarity here between the human and the machine readable text, but you wouldn't ever give the text on the right hand side to a human to read. It is just about possible to understand without a technical knowledge of CQL what's going on here, but it certainly isn't human readable. But it is computer readable and computer executable, and that's the important thing about it. So that's an example. Next slide. So the challenge we have at the moment is that on the right hand side you've got the decision support system developer, or developer of an app, or a medical robot. They need a knowledge base which will then be used to give advice or risk score to the user. But their challenge is to get that knowledge out of a guideline document that's been produced by a practice guideline development team based on research studies and systematic reviews. And at the moment, that's a reverse engineering process, which is fraught with difficulty and hassle, and takes a long time, and may also be prone to error, because the kind of people who are writing the knowledge bases aren't necessarily the kind of people who are familiar with the domain and the language used by practice guideline teams. And in addition, it's also possible that sometimes the practice guideline development team may not express their findings and their conclusions and their recommendations in a sufficiently tight format that it can be accurately represented in a knowledge base. There may be, for example, paradoxes or missing information, or even they may refer to the same clinical concept in two different ways, and it's not obvious that there's actually the same clinical concept being referred to. So you can begin to see why it can be not only time consuming, but also full of hassle for the knowledge engineer trying to turn a guideline PDF document into a computable knowledge base. What we need, next slide, is some way that the guideline developers or the guideline development team can actually, at the same time as producing a text document, produce objects that correspond to that, to the important and relevant bits of the guideline that need to be turned into computable form. And it probably isn't going to be all of the guideline. It's probably only some of the recommendations that are made that need to be translated into guideline knowledge objects. And then those knowledge objects can be stored in a clinical knowledge objects library, which can then be drawn on by decision support system, app developers, developers of medical robots, whoever, without really further human intervention. And those will automatically become the knowledge base for their system. So that's the vision of the Managing Computable Knowledge Coalition. And if we look at the next slide, there's really a grander vision here. So essentially what the MCBK coalition would like to do is to produce a global index library of knowledge objects. And of course, it needs to have security systems, probably charging payment systems as well. The whole thing's got to be sustainable, and it will contain numerous knowledge objects. And if you look first at the green box within the knowledge object, that's the knowledge payload, as that people are calling it, the algorithm, the rule, the score, whatever it is, the knowledge object. But in addition, that knowledge object needs to be referenced, it needs a date, it needs a source, it needs metadata. In other words, what coding systems are used, what keywords, how can it be indexed? There's a lot of metadata which people are discussing, and which there's emerging standards for that metadata for clinical knowledge objects. And then those knowledge objects can be searched. So if you just hit the next key, Joe, thanks, through a search engine. And used by a whole range of knowledge users. We've talked about most of these. And the contributors to that knowledge objects could be a whole range of different people or organizations. We've talked about guideline authors, maybe patient groups, professional groups, maybe the FCI, health maintenance organization, journal publishers, a whole range of different organizations could potentially be contributing. So that's the overall vision, the grand vision, if you like, of the MCBK coalition. There are, of course, some challenges. Next slide. One of the biggest ones I mentioned already is sustainability. How do we justify the extra work of authoring this computable knowledge, as well as the human readable text? There probably needs to be some kind of charging system, for example, for use of the knowledge, which then gets fed back to the people who contribute objects that are used. But another and perhaps bigger challenge is building user trust in the library. And there are a whole range of things that I think will lead to user trust, quality assurance and validation, perhaps the most important, but also things like preserving the context of knowledge objects, keeping them up to date, ensuring safe transfer to systems that use different clinical codes or semantics. And we've got one example at least in the case of Curious 2, in which unfortunately a really good algorithm didn't work well in a primary care system because they were using a different coding system. So the Curious 2 algorithm gave the wrong risk estimates for a period of time. Another big issue I mentioned already is the quality of the knowledge objects. We want to make sure that an object based on a nice guideline or system overrules objects based on a single study or even an expert opinion. We need to build in some kind of CQI process, for example, by routing user comments on knowledge objects back to the authors of those knowledge objects. And we also need some kind of governance structure and mechanism for MCBK, which needs to be as lean and as simple as possible. So there are some challenges around this vision. It's a great vision, but it's not that easy to realize. Next slide. Another challenge is that clinicians need skills to be able to use these tools, and they need them for their clinical work, and there's a range of different things. For example, just recording accurate coded data to support machine learning and make sure that any advice from a decision support system is likely to be accurate. Knowing what AI is, recognizing when and where it's being used, trusting and following the advice when it's correct, and recognizing and reporting errors when it's not correct. Clinicians are often involved in education, so educating colleagues about appropriate use of AI, recommending appropriate AI to patients. And then finally, some clinicians get involved in advisory work, helping to procure AI systems, for example. And that is a special skill. And what should you look for? It is a good question, and something which maybe the AI SIG would like to discuss. Investigating adverse incidents involving AI decision support would be another example of advisory work. So moving on, we do now have an activity in the UK. We started off with a workshop last October, and the aim of this activity is to support UK organisations to adopt high quality computable knowledge and realise its benefits. And you'll see there's a range of activities that we're carrying out, including building on the conference that we had last year, and we're hoping to organise a conference in early 2021. There's a lot of information about the MCBK activities in the UK. If you look at the Faculty of Clinical Informatics homepage and the link of that, there's also recently published, thanks to Philip Scott's work, 7 articles in BMJ Health and Care Informatics, and there's a link there. I think you can find it pretty quickly if you Google it. So there's a lot of background information with articles from NICE, from HDI UK, from Manchester, etc., which I think you'll find interesting if this area interests you. Next slide. Philip and myself are also closely involved with HDI UK now. We're jointly directing a work stream, the Better Care programme. The aim of that is to improve all types of knowledge flows within and beyond the Better Care programme. So that includes both tacit knowledge and explicit computable knowledge. And currently we're carrying out surveys and interviews on current knowledge exchange habits and wishes, auditing clinical knowledge products, option appraisal of current computable knowledge standards and tools. And Philip is going to be setting up a clinical knowledge hack day in December using the selected tools to see whether we can get people from Better Care and other people to use some of the tools to encode clinical knowledge. I'm sure Philip would be happy to talk about that a little bit later. There's a brief description of that work stream on the HDI UK website there. So in conclusions, I hope you would agree with me that knowledge is central to clinical practice, but it is sometimes hard to manage. There is good evidence that knowledge systems improve clinical decisions and patient outcomes. I gave you the systematic review evidence there. Computable knowledge is the core of these decision support systems, but not just decision support. A whole range of other systems need computable knowledge. But it's hard to capture the knowledge of those systems. It's hard to locate the good knowledge, and it's hard to include it. There is a great deal of interest in a global clinical knowledge object library, which we think is within reach, but it does raise a number of trust and technical issues and sustainability as well. We've got this special interest group within MCBK, on MCBK within the FCI, which is working with the United States and other groups to progress this agenda. So if you're interested in this area, please do take a look at the material on the FCI site about MCBK, and there is actually an expression of interest form that you can fill out if you'd like to become part of that special interest group. So I think I better stop there. Sincere apologies about the broadband challenges. I've had extensive discussions with engineers. There's one coming tomorrow to fix it. I couldn't persuade him to come yesterday or this morning, unfortunately, and even my backup tethering on my phone didn't seem to work reliably. But anyway, I really look forward to your comments and suggestions. So over to you, Joe.
Okay, great. Thank you, Jeremy, for that. So we could just, if anyone has any questions, please feel free to put them in the chat, or you can put up your hand as well if you're happy to ask them. If there's any questions around Jeremy's presentation and MCBK in general, do let me know. And otherwise, we can also kind of discuss any future topics for the AI SIG in future. But does anyone have any questions or would like to ask Jeremy anything?
And delighted that Sue Lacey-Bryant has joined us as well. Sue is the Director of NHS Libraries at Health Education England. And I see, Sue, you made a comment that it's hard to keep knowledge updated. And I think that's a very good point, that knowledge is not much good in the current evidence-based world if it isn't kept up to date regularly. And again, I'm sure that NICE, we know they invest very significant resources in keeping their knowledge updated, their guidance updated.
Good to be here, Jeremy.
Thanks. Philip, do you want to say a word or two about the side of the project that you're involved with?
Yeah, sure. Happy to do so, Jeremy. Yeah, so specifically the work leading up to the Computable Knowledge Hack Day in December, we're still at a very formative stage of deciding what the scope of that is going to be. So I would certainly welcome any thoughts from people in terms of where you would see low-hanging fruit. Where are there opportunities for computable decision support to kind of move on from where it is now? There are various things which are kind of already embedded in terms of things like drug interactions, drug allergy interactions, but also some decision support failures in the past where things have not integrated very well with EPRs, or there's just so many alerts, people just click through them. But it would be interesting to hear if people have any thoughts on areas where decision support would be welcomed. I guess the other thing is that in the Hack Day, obviously we are looking to try and solve real world problems, and one of the real world problems is, just as there are still challenges with data interoperability, there are even more fundamental problems with knowledge interoperability. And so having this kind of central library, or even a distributed set of global libraries that Jeremy was describing, there are a number of emerging standards that seem to be being favoured by, for example, the CDC and the ONC in the US. And I think, given the kind of commercial power of the US and the EPR vendors that are from that market, it just seems to me pragmatically that's likely to be the way things go. But equally, we also need to think about interoperability with what I suppose we might describe as legacy products or existing knowledge management products. So again, we're very keen to hear from people in terms of what would be useful to include in the scope of the Hack Day, and equally what wouldn't be useful, where you think perhaps there are things that have been tried and already demonstrated to be not worth pursuing.
Thanks, Philip. And I see we've got a couple of comments. First of all, on the lack of current standards from Karnesh Patel. Thanks for that. Hard for a decent national referral system. Yes, and it makes it hard to consider any AI data analysis in many areas. Few providers using the same thing in the same way. There's a very good point that you make there, Karnesh. Would you like to add anything to that, Karnesh?
Thank you. Very interesting talk. I guess I could just expand upon that for people that didn't quite get perhaps what I was meaning as a clinician in the NHS. One of the things that we're finding, and for context, I work in ophthalmology, is we want to regularly integrate our software from an EPR point of view with what the trust is using. And this is a similar issue for other specialties and other trusts around the country. And you find that those pieces of software don't talk to each other as much as either the manufacturers claim or that you want when you actually try and go and do that integration work. And a lot of the times is that the same data sets don't exist in both pieces of software. You can't easily map one thing to another. And this is something that actually we've had a discussion with NHS Digital about in terms of ophthalmic referrals on a national level, in terms of audit and data collection to guide workforce practices, etc. And we haven't yet got those kind of standards to say actually all systems with the NHS ought to follow this data set. Every piece of data has a standardized ID, so it doesn't matter who makes the software. everything will always map to everything, no matter where, because that ID cannot be used by anything else. And it's always that piece of data, and that would make things so much easier for anything in the future, because you know that you will always be able to port that information and data from one system to another, and it would be understood in the exact same context.
Thanks very much. And you start by saying the lack of current standards. I think part of the problem is the proliferation of standards, and what's needed is agreement on which standards software across the NHS will use to ensure interoperability. And I think that is one of the areas that NHS X and NHS Digital are working on, at least I hope it is currently. Philip, you might have more insights about that.
There's certainly, I guess, on two levels. One is in terms of information content. There's the work that PRSB is doing, which is getting increasingly granular. I mean, it started off very high level just as record headings, but over time has got more detailed, and that is now getting better linked up with the work that NHSX is commissioning from NHSD in terms of the technical stuff. So there have been, there's internationally there's the FIRE standard, but again NHS has made slow progress. I think it does seem to be accelerating now, but there is this international standard that can be adopted for data interoperability, and clearly we need that, as you rightly say, as a foundation before we can think about the more higher level challenges of knowledge interoperability.
Yeah, and the PRSB, that's the Professional Record Standards body. And Philip, you've been involved with them, I think, for a little while, and they do a lot of interesting work on standards and actually cross-professional work. So bringing in between 20 and 30 different professional organisations, as well as user-patient organisations. So perhaps something a website to look at. The second comment here, Dr. Joshi, is it possible to complete the expression of interest as an individual? Yes, it certainly is. Please do. Andy Webster, risk prioritization for clinicians for decision support. If I'm assessing patient A for condition B with additional factor CD, what's their risk or harm if I send them home? Indeed, that's exactly the kind of scenario where decision support systems can be very helpful, as long as they are developed using appropriate data sets and validated similarly. And it's good to hear that you're making early steps for decision support for emergency care, just scoping out a project. Ganesh Arunachalam, apologies for the pronunciation, I have got that reasonably close. Simple rule request report cycle for investigation could reduce burdens. Yes, absolutely. Related proposals for the hack day. So this is about managing investigations, and as I understand that some systems in the United States, some audio communication systems do have a potential to add rules to, for example, if you've had a hemoglobin assessment within the last 3 days, then the advice would come and say, do you really need this extra investigation? It's unlikely to have changed unless it's somebody who's acutely bleeding, in which case actually will be a misleading result. So yeah, absolutely, and that some systems do already incorporate rules for the request report cycle, and actually also allow you to annotate or interpret the results. And I see there's the content not supported through SNOMED. Well, yes, there are a whole range, as you said, there are a lot of standards out there, SNOMED being one of the main ones. Someone else, Anna Moore, is developing an early identification of mental health problems to use the community health signposting. So that sounds like that would be a system for patients and the public to use rather than for clinicians. Is that right, Anna, if you're still with us? Maybe you're muted. Martin O'Keefe comments, yes, NHS Digital has a new commission to develop interoperability standards across the UEC space. This will start with the period of discovery. I don't know what the acronym UEC stands for, Martin. Are you there?
Yes, I'm here. It's the urgent emergency care space.
Urgent and emergency care space. Thank you very much. Right. And there's a comment back from Karnesh about Snowbit. One of the problems with Snowbit is, of course, that there's more than one combination of codes possible for standard diagnoses. So, for example, appendicitis, I think there's a specific disease code for appendicitis, but you can also code it as morphology, inflammation, topology, appendix. Yeah, right. Any other comments here? Very confusing for people to use, says Karnesh about Snowbit. Okay, I had a couple of questions for those who are still with us. Oh, right, there's a comment here from Johanna Hume. You mentioned guidelines currently present PDFs translated. What do you think of the opportunity challenges for presenting guidelines in more computable format upfront to minimize the translation? I think that's a very, thanks for that question, Johanna. You're absolutely right that potentially, if we started by representing guidelines in computable format, we could then carry out validation of the guideline, looking, for example, for missing information, or looking for inconsistent definitions of clinical entities, looking for paradoxical recommendations even. So that would be one advantage of starting off by representing guidelines in computable format. You then can use automated tools to validate the guideline. In addition, you can potentially use natural language generation tools to generate the text version of the guideline in a variety of different formats. So you could generate a technical version for clinicians and a version for patients in patient appropriate language. You could even generate a version in Urdu or another language for patients or different communities. So yes, there are a number of potential benefits of representing guidelines from the start in computable format. However, I'm not sure that we have the technology yet to capture the richness of some of the relationships that are expressed in guidelines. For example, quite often guidelines include language like patients with X and Y may be suitable for referral, or some patients with X and Y should be referred. So clearly the concepts of probability and so on can be more tricky to represent. And yes, someone points out that this would be useful for primary care. And we are including NICE in the hack day to explore whether computable knowledge could be useful to them. And there is already Andy Mitchell is an advisor on our project and is actually a member of the MCBK UK steering group, Andy Mitchell from NICE. I was going to, yes, representing the independencies, says Sue Lacey Brown, will be the holy grail, and that's absolutely right, that we can't currently represent the subtleties of human language in computable language, and I think that's where we have to recognize our limitations and only try and represent things which are, if you like, categorical relationships. I got a couple of questions for you. First of all, this is the first activity of the AI Special Interest Group. And has anybody got any suggestions for other webinars or other activities, maybe a workshop? And I'm thinking, for example, of a workshop around validation of AI algorithms. Is that something which would interest anybody who's on the call? I'm not seeing a lot of interest there. Perhaps you could, right, okay, here are a few people responding. Actually, yes. That's great. So that's good to hear. Is there anybody who feels specifically that the validation of AI or other topics for webinars that people would like to see, apart from validation, which I assume is what those yeses are about? So if you could perhaps add some other suggestions for topics and maybe even speakers, that'd be really helpful. We've got a deluge of yeses for that suggestion, so that's great. And then, as well as other topics for webinars, are there any other activities? For example, what kind of other activities do you think would be useful? And one suggestion might be a survey. We recently published a survey carried out at the College physicians on specialty societies' views on AI, the opportunities and the challenges of AI. Would that be useful to have an FCI survey of that, of the entire membership? So a survey, a workshop. If you've got any ideas, please do let us know. And you can email me or Joe. I hope that you'd be happy to have ideas emailed to you.
Yes, yeah, definitely. I'll put my email in the chat.
Information governance required to allow data to be shared. Yes, that is a very big issue. However, Hannah, I'm afraid when we set up this AI group, we said, well, actually, there are other groups who are active in information governance, and that we knew that this could take up a lot of the group's time, and there were other issues that we'd also like to discuss. So we kind of shelved that for a bit, but we could certainly suggest a webinar on that or a workshop on that, if that's something which several of you would like to get together and discuss. Jonathan, you've just given us a link to an article in Nature and suggest that we should have a journal club on that. And scalable, accurate, deep learning with electronic health records. That's a publication from May 2018. Thanks for that. So yes, and Joe said, please send any suggestions to him, and that he gives you his email in the chat. Yes, developing a clinical assurance framework. Thank you, Martin O'Keefe, for assuring AI in healthcare would be very useful. And yeah, we know that that is actually on the agenda for the AI lab at NHS X. So anybody who's interested in that, please do contact me. Sue Lacey-Bryant, what critical tools will we need to evaluate bias within the tool? And this is one of the big concerns about machine learning, of course, that we could bring in unintended bias into the algorithms that we generate. Right now we have healthcare staff, clinicians, knowledge specialists trained to discern bias in published research using CASP and other critical appraisals. How are we going to tackle this for AI? What tools and learning and CPD we need? Really interesting question. Thanks, Sue. And it's linked to how do we define bias within tools. And Sophie comments that I'd be really interested in human factors, safety and interaction issues. And there's some really interesting issues there, Sophie. For example, there's something called automation bias. And we've done a systematic review on that a few years ago. Essentially, what happens is that humans tend to treat computers as having greater power and accuracy than they really have. And this was shown in airlines. Well, pilots tend to follow their instruments, even when the instruments are giving them the wrong information. They will ignore a mountain in their view if the instrument, the altimeter says, no, there's plenty of altitude here. So automation bias, and we know that also happens with decision support. If a decision support system gives you the wrong advice, you can still follow it even when your intuition is to go against it. So yes, there's some interesting yes, and Philip, you point out like the A-level algorithm. Yes. What can be learned from criminology? Yes, and off qual. Yeah. Yes, absolutely. And this issue, Sophie, you comment on, the clinician can see the working of algorithms and avoiding black box type systems which cannot explain themselves. And there's some big legal issues around those as well. And currently, black box algorithms will not be approved within the UK. I sit on an MHRA group which has discussed that. A link to new or existing ISO standards for AI components. And yes, I've heard that there are some standards under development. Thanks, Robert, for that. So we talked about future topics. Another thought or question is, I mentioned that there is already an MCBK special interest group of the FCI, which I currently chair along with Philip. It's a joint working group between the BCS and the FCI. And one question, of course, is whether there's really a difference between the AI SIG and the MCBK SIG. And I'd be interested in any views on whether it seems rather arbitrary having two separate SIGs, whether there is a disadvantage to having separate SIGs, or whether there is indeed an advantage. And I would suggest straight away that the MCBK SIG really doesn't cover machine learning very much. It's more about explicit knowledge, for example, guideline knowledge that then is transferred into computable format. So I think that the whole area of machine learning might be lost a little bit if we tried to merge the AI and the MCBK groups, but other people may have a different view on that. Again, if you've got some thoughts, please email me or Joe, because I think it's an interesting and provocative question. But meanwhile, I think what we'd like to do is to keep the AI SIG going in parallel with the computable knowledge SIG, and maybe review that at the end of the year or early next year to see whether there is a benefit in merging. But if you've got any thoughts or views on that, then I'd be really interested to hear from you. I see we've got 2 or 3 minutes left. Is there anybody who hasn't commented or spoken, or who's got some burning issues they'd like to raise for the broader discussion? I'll give you a minute or two to type in the chat or raise a hand. I can't see any hands raised. I'm going to turn my camera on again rashly. I hope that doesn't crash my broadband, looking nervously at the router behind me. It's been a really good discussion, and I hope we'll be able to capture the meeting chat, because there's been a lot of really interesting comments and suggestions, questions and so on here. So I'm keen to organise another webinar or potentially workshop session, maybe not in August when a lot of people are away, but in September, October. It would be good to keep up the momentum that we've established here. So watch this space. We have a small steering group, and we will meet again soon and discuss some of the comments. In relation to, so Karnesh, you've commented something here. Joe, would you like to wind things up?
Sure. Yes. Yeah. Yeah. Just as Jeremy was saying, I'm happy to collate all the comments in the chat and for activities for next steps, and I can send them to you, Jeremy. This has been recorded, so I'll upload that afterwards for people who haven't seen or to watch back. Jeremy, are you happy for the slides to be shared with people?
Absolutely. Yeah.
Okay.
Yeah, no
great.
problem.
I'll share a PDF of that as well. And yeah, then I think that's everything. So yeah, no, thank you everybody for joining. Thank you very much, Jeremy, for the presentation. It was really interesting and a good discussion. And yeah, I look forward to what comes next.
Great. Thanks, everybody. Brilliant.
Thanks.
Bye then.